Good afternoon, everyone. Thank you, Fawzia, for such kind introduction. So we have learned till now various aspects of neonatal ventilation, and now we will learn about the weaning and extubation. So we'll talk about the why weaning is important, then what is the natural course of a baby on a ventilator, and then we'll talk about the weaning strategies, the extubation checklist and timeline that we need to follow, and then a case scenario about the difficult extubation. So as we know, that ventilation has been boon for some babies, but then it can also quickly turn out into curse because of repeated reintubations or prolonged duration of mechanical ventilation, which can lead to a ventilator-associated lung injuries. So we need to reduce these. There is no consensus about appropriate way how to wean the babies. Either delaying the weaning or either weaning too early, both can pose risk, and therefore understanding the natural course of the disease is very important. We need to weigh against the risk of deterioration of the ventilator and also in case of difficult intubation. So this is how our respiratory journey of a extremely premature baby proceeds. So, immediately after the delivery, baby is stabilized on delivery room CPAP. Then we might get the baby surfactant using Lisa or initial, and then thereafter we can stabilize the baby on CPAP. In some cases, the baby might need to be intubated. In that scenario, we need to give the tidal volume 4 to 6 ml per kg, and then the baby can be subsequently extubated to CPAP or HFNC. This is usually in the early case of RDS. Then, suppose if the baby is continued to ventilate it, then we move into the evolving phase of BPD, which is from the day 14 of life to 36 weeks of post-mutual age. Uh, Most of the time, the causes of the failure include either sepsis, NEC, or PDA. Majority of the times, we encounter these situations very frequently. Then, supporting aids can be either systemic steroids or diuretics. Then, further, the child can go into the established PPD. And most of the time, the reasons are different. There can be background PPHN, there can be poor nutrition to these babies, there can be airway anomalies. And the definitive treatment that can be given are the use of steroids, diuretics, sildenafil, chest physiotherapy. So in this scenario, we need to reassess the respiratory airway as well as the parenchyma. We can proceed with the tracheostomy, and some of the babies might require long-term ventilation. So um, these babies can be extubated to HFNC, CPAP, or NIPT depending on the situation. So what is weaning? In weaning, for that smooth transitioning, we have to be vigilant. Early weaning helps in reducing the risk of nosocomial sepsis. It helps in reducing the patient discomfort and need for sedation. Minimize the development of oral aversion, and therefore it helps in development of oromotor stimulation and subsequent minimization of the feeding difficulties. It also helps in promoting the parental bonding and development supportive care. Various strategies have been employed for weaning, which includes the permissive hypercapnia, in which the PCO2 levels are kept between 45 to 65 millimeters of mercury. It helps in reducing the ventilator-associated lung injury by providing lower tidal volumes, giving lower PIP, and this helps in better cardiovascular stability, providing there is better cardiovascular stability, there is better ventilation perfusion matching, the mismatch is minimized, and also there is smooth ventilation. Various studies have been done, which showed that, like Felby and support study, which showed that practicing permissive hypercapnia beyond 65 millimeters of mercury might not be that beneficial. Then permissive hypoxemia, that also can be practiced, but then from various trials like Neoprom, which comprised of the meta-analysis of 5 studies, it showed that the saturation levels which should be targeted is between 91 to 95 for both the term and the preterm babies. Then we should have weaning protocols. One study showed that 36% of the ICUs only have weaning protocol, and so all over the world, not many ICUs and ICUs are not having the weaning protocols, which we can employ. Adjunctive therapies can also help in reducing the duration of mechanical ventilation, such as caffeine, which can help. Caffeine, we know that it reduces the duration of mechanical ventilation need for and then not all the PDA should be treated, but those babies on mechanical ventilation who have hemodynamically significant PDA on case-to-case basis, these might require either medical or surgical correction. Then avoidance of sedation and nutritional therapy, which forms the backbone of any NICU, and prevention of osteopenia prematurity. Then chest physiotherapy, use of systemic steroids, as we have learned through various meta-analysis. The recent one from the Ramaswamy et al. From 2021 suggests the use of moderate dose of dexamethasone, 2 to 4 milligram per kg over a period of 10 days is but helps in extubation. Then use of intratracheal steroids, which can help in facilitating the extubation, but at the cost of mortality. So that also has to be weighed. So how do we define that the child is ready for extubation? So these babies should have the respiratory drive. They should have minimal distress, and the underlying disease process should be resolving. These babies should be hemodynamically stable, and there should be minimal inotrope support or either no inotrope support. The baby should be on the peri-extubation settings, which is already decided. Then there should be appropriate mental and neuromuscular status with minimal or no sedation, as already talked. The child should have appropriate acid-bridge status. The hemoglobin should be appropriate, and there should be no dyslipidemia. So parameters of blood gas with prior to extubation, the pH should be more than 7.20. We should remember that permissive hypercapnia should not be practiced within first 72 to 96 hours, because it can lead to IVH. Not only the high levels of PCO2, but also the fluctuations in PCO2 can also lead to IVH. So permissive hypercapnia is best avoided in initial days, and thereafter we can practice permissive hypercapnia. Then we should see that there is no metabolic acidosis in the blood gas, and the hematocrit is optimized. So there was this study based on the lung ultrasound and echo parameters, which help in predicting the extubation. So this was done in the RDS babies. You can see there was scoring in the 6 zones, and depending on 6 zones of the lung, which included the anterior chest wall, right upper and right lower, left upper and left lower, and then in the axillary areas of the two sides. So zone 0, in which we can see the A lines, as ma'am had already told. Then score 1 was given for those babies, those zones with the B lines. Then score 2 was given for acute interstitial syndrome, which comprised of the confident and compact B lines. Then a zone 3 was given for the underlying consolidation. So it was found that lung ultrasound sonography scoring can predict the extubation success in preterm infants with RDS, especially in those babies who had lung scores less than 10, and those with more than 10 had difficult extubation. And also the left ventricular eccentricity index can help in prediction and help in determining the pulmonary artery pressures. So which mode should be preferred? As we have talked that not all the modes have much advantage over each other, but volume target ventilation is definitely may help in accelerating the weaning. Then there are other modes such as pressure support, SIMV plus pressure support, and then SIMV alone. These modes have one and the other have side benefit only. SIMV pressure support might have some benefit over the SIMV. So we should always attempt early weaning. Physiologically, as I told, volume guarantee is better than the assist control, and then which is in turn is better than the pressure support ventilation standalone, which in turn is better than SIMV plus PSV in terms of weaning, and then SIMV more load. As we know that oxygen is harmful, can cause toxicity. So FiO2 should always be weaned first in comparison to PIP. And as ma'am had already told, we should try to change only one parameter at a time, so that in case of worsening of blood gas or in case of increased work of breathing, it is easier to regain the stability. So one of the most important point is that we should remember that pH determines the expiratory drive, and it is not PeCO2. So we can tolerate permissive hypercapnia in babies. We should, but initial days we should avoid increased rise in PCO2, which is more than 65 millimeters of mercury, or increased fluctuations in PCO2 during the initial days. If there is an increase in, if we want to increase the PCO2 for practicing for basal hypercapnia, we can decrease the PIP and rate. And if we want to decrease the PO2 for permissive hypoxemia, we need to decrease the FiO2, and we should not decrease P less than 5. So the setting should be decreased every 4 to 6 hours, and PIP should be reduced in units of 2 to 3 centimeters of water, and FiO2 should be weaned from 5 to 10% every 4 to 6 hours. Then PEEP can be reduced by 1, but it should never be reduced below 5 because of physiological issues. And then the rate should also be weaned. Most of the time I see in ICUs is that we are not weaning the rates. So that should also be weaned. Inspiratory time should be kept between 0.3 to 0.4 seconds. And we should reassess using blood gases as and when needed. So the ideal peri-extubation settings include a PIP of 16, which can it can be even smaller in the preterm babies, which can be between 12 to 15. PEEP should be less than 6 centimeters, and rate should be around 30. FiO2 should be around 30%. And resulting map for term babies should be 8 centimeters of water, and for preterm babies, it should be 7 centimeters of water. And some babies with the BPD might need to be extubated from the higher settings. So this is how proceed weaning in a baby who is on the pressure control ventilator. So the child can either be on SIMV plus PSV mode of ventilation, or either the child can be on assist control or pressure support ventilation. So these babies, once the saturation is in the normal range for 94% for the term babies and 91% for the preterm babies, we should start decreasing the FiO2 first in units of 3 to 5% every 15 minutes. Then if the child is comfortable, there is no tachypnea, no work of breathing, there is not much work of breathing, and PSU2 levels are within normal range, then we should start decreasing the PIP once the FiO2 has reached to 40% in 1 to 2 centimeters of water. Then blood gas should be repeated every 30 minutes. Once the acceptable blood gases have been reached, so for example, platelets is more than 7.25 and PCO2 is between 45 to 65 milliliters of mercury without any prominent metabolic acidosis. Then suppose our child is on the SIV plus pressure support ventilation, then we should continue weaning the PIP further until and FiO2 alternatively till the PIP is about 20. And once the PIP is less than 20, then we should start weaning the rates also. And if the child is on SIV mode and already the pressure support ventilation is not added, then we can add the PSV also. It should be roughly around 30 to 50% of the PIP minus PEEP. And we should ensure that the tidal volume generated from the spontaneous breath should be at least 4 ml per kg. Then subsequently, we should reduce the PEEP if it is high, more than 5, but it should never be less than 5. Then we need to reduce the, we can further reduce the rates. And once the rates have been weaned, then we need to check for the child is spontaneously breathing. Then we should have a extubation checklist, and we can give the spontaneous breathing trial. So what is spontaneous breathing trial? In this, the baby is put on the ET CPAP, so endotracheal CPAP on the pre-extubation settings, and the child is kept for 5 minutes and rise either if there is a fall of SpO2 less than 85%, or there is bradycardia that is less than 100%, on increasing the FiO2 up to 15% from the baseline, and still there is fall, then the test is considered failed and the child cannot be extubated. But using spontaneous breath test is controversial. It should not be used in every baby, and especially for the extreme preterm babies, in which cases it can do more harm. So once the checklist has been ticked, we can extubate the baby either to a CPAP, HFNC, or non-visible ventilation, and IPP. Then if the child is on assist control ventilation, similarly, we have to wean the PEEP and FiO2. And if the child is on pressure support ventilation, standalone, then we should see that there might be increase in work of breathing. In that scenario, we need to increase the FiO2 because the PI can be too short and it can lead to atelectasis. Once the PIP has been reached to the exit settings and the backup rates are reduced, then we can extubate the child. So now moving on to the checklist and the timeline. So once the child has achieved the pre-extubation settings, so at before 24 hours, we need to discuss with the clinical and nursing team. Extubation should be planned and well documented. The setting should be uh, decreased and sedation should be stopped at least 12 to 24 hours prior. Hemoglobin should be optimized. It should be under control. Caffeine, if not already should be started. Then hemodynamic stability should be ensured, and reasons for the prior extubation failure should be evaluated. Then the family should be informed and informed. Then we can consider using the dexamethasone, which can be given 4 hours prior to extubating the child. The dose is usually 0.25 milligram per kg. It can be given 8 hourly, 3 doses. And then at the beginning of the shift, so the staff nurse, the unit should be well equipped, and there should be mix of experienced nurse and who should be well skilled also. So again, the extubation can be planned in the morning prior to rounds. 2 hours before the extubation, the child should be evaluated by the clinical team, and optional changing to PSV can be done, and SBT is also optional. Then feed should be stopped, and if there is no IV cannula, the child can be put on the IV fluids. IV cannula can be put on IV fluids. Then 1 hour prior, the machine should be kept ready. Either the mode of extubation should be pre-decided, whether you want to extubate the child on CPAP or HFNC or an IPP machine. Then it should be kept ready. The interfaces should be arranged, and suction of the endotracheal tube in the nasopharynx should be done. Then RV should be checked if the fluids are already stopped. Then 30 minutes prior, you should assess minimal handling should be done in the patient care, and necessary handling should only be done, such as diaper change. You should check the position of the OG tube. Then senior staffing should be present. So once you have decided to extubate the child, the baby is more than 28 weeks of gestation. These babies can be extubated to the HFNC or CPAP. None of the one mode has the benefit over the other. In babies less than 28 weeks of gestation, CPAP is the preferred mode. And those babies who have required ventilation for prolonged duration, in these babies, NIPPV can be given. So once the child has been extubated, the child can be kept home or swaddled. To it also, we can ensure that the pressure is not lost due to mouth opening. The pacifier can be used, and we can send the blood gas after 1 week. So post-extubation adjunctives include caffeine nebulization with the epinephrine, which can be done in the dose of 0.55 ml per kg. Maximum of 5 milligram can be used. Then diuretics can be used. Chest physiotherapy should be done, and inhaled or systemic steroids can be used, and ongoing monitoring and evaluation should be continued. So some of the babies might require reintubation also. We have to look for the signs of whether the signs of increased work of breathing is there, or there is frequent apnea are there. There is increased in FiO2 requirement, which should be pre-decided. Suppose if you decide to reintubate the child on 60 or 70% of FiO2 requirement, then if the child is requiring more FiO2 than that, then the child should be reintubated. And if there is persistent respiratory acidosis, then also the child needs to be reintubated. So at many times we find difficult scenarios, such as the baby is on baby is having severe BPD and is stuck on the ventilator, and we are not able to wean these babies. So in that scenario, that typically we should give higher tidal volumes, as function I have already told, about 7 to 12 ml per kg. Higher feeds might be required for this baby, and with higher TI and ventilating at a lower rates. So we need to optimize the growth for this baby. Higher calories are required. We need to manage the osteopenia prematurity. Anti-reflux medication can be given, such as domperidone, and then fluid restriction can also be done. Then we need to optimize the neurodevelopment, such as an ISO environment has to be controlled and minimal sedation has to be given. Then the baby should be stabilized on the steady respiratory support with optimal PEEP, increased expiratory time for reducing the auto PEEP. Then BPD spells should be addressed, and we should have BAP bundles to prevent ventilator-associated pneumonias. Then PPHN should be avoided, or either it should be treated. So after the baby has reached the post-menstrual age of 36 weeks of gestational age, we can give higher levels of oxygen, 94 to 98, because oxygen itself causes vasodilation in the pulmonary circulation. Sildenafil can also be used. So suppose the baby is improving, then we can contemplate extubation, and we should slowly wean this baby to an IPPV. But if the baby is not If the baby is not improving, then we can consider the bronchoscopy or virtual bronchoscopy. Suppose the child is having frequent BPD stress, in this scenario, the bronchoscopy can be considered, or if there is no improvement, then echocardiographic for pulmonary artery pressure assessment, CT MRI can be done with virtual bronchoscopy. Tracheostomy can be done, which reduces the work of breathing, and there is better oromotor development and neurodevelopmental outcome. Multidisciplinary team approach with the help of the ENT specialist and nutritionist can be done, and nurses can be done. So the take-home messages would be: you should plan your weaning immediately as soon as you intubate the child, and there should be once the child achieves the minimal mean airway pressures in 5-2 requirement, we should start weaning the child. We should have a checklist for extubating the child, and the success depends on the multidisciplinary pre and post extubation plans. And the most important thing is nutrition, which forms the backbone of an ICU care. Thank you.